Hello, everyone. It is my pleasure to welcome you to our September Metastatic Breast Cancer Impact Series event. My name is Casey Volpe, and I'm the manager of MBC Initiatives here at Komen. The programming for this series is envisioned as a year-long conversation. So every month we do a different topic, different speakers, all at the request of you, attendees, and patients. Today, our topic is the research and treatment landscape for HER2 positive metastatic breast cancer. We have a fabulous speaker by the name of Dr. Adrienne Wax from Susan F. Smith Center for Women's Cancers at Dana-Farber Cancer Institute. My apologies, it's not a tongue twister. I just can't speak properly. And our fantastic moderators, Julia Hughes, NBC advocate and current member of our NBC steering committee. Before we begin, I just need to do a quick thank you for our sponsors supporting the 2025 NBC Impact Series. So thank you to our premier sponsors, AstraZeneca, Gilead, and Merck, and to our signature sponsors, Daiichi Sankyo and Novartis. One quick housekeeping note, while our speakers are talking and presenting, please feel free to post your questions in the Q&A feature in Zoom. This is different than the chat. It's down on the center of the presentation screen. We will get to as many as we can at the end of the presentation. We will go until we run out of time. So feel free to put those in there and we'll get through as much as we possibly can. Please remember that our speakers are not able to provide individual medical advice, so do your best to keep your questions as general as possible. Towards the end of the program, we will put a link in the chat. This is really important and helpful to us as we design these topics in this program to make sure that it's valuable and impactful for you. So please don't be shy. It only takes a few moments and it will determine what we present on and when we do it. So without any more delay, I am excited to introduce you to today's moderator, Julia Hughes. For over 10 years, Julia has bravely faced the challenges of living with metastatic breast cancer, starting from her diagnosis in 2015. It's with a deep personal commitment to breast cancer advocacy. She possesses exceptional skills in communication, organization, and fostering community support. At Komen, she plays a pivotal role in addressing the needs of the NBC community, ensuring that diverse voices and perspectives are heard. Despite the unexpected stage 2 diagnosis in February 2015 and the grim prognosis later that June, with doctors foreseeing only 6 months to live, Julia's unwavering faith has propelled her through the tumultuous journey of treatments and surgeries. She's endured over 55 IV chemotherapies, brain surgery, double hip surgery, and ongoing oral medications. Her resilience stands as a testament to her strength she derives from her faith. She also happens to be an incredible fundraiser. She's fundraised for Komen Hawaii, leading the top ranking teams in generating vital funds since her diagnosis in 2015. She's a sought after speaker and has graced the stages of Komen's Pink Tide Ball in 2019, 2023, and 2024. Recognized for her remarkable advocacy, she has received the More Than Pink Inspirational Award in Hawaii and was featured prominently in Generations magazine, raising awareness of breast cancer across all age groups. In 2023, her passion for advocacy reached new heights as she successfully campaigned for Honolulu's mayor to proclaim October 13th as NBC Awareness Day. Her influence continues to grow as she serves on the NBC steering committee and has since 2022, eagerly anticipating further opportunities for impactful service. In tandem with her official advocacy responsibilities, she aims to bolster her presence on social media, delve into book writing, and forge partnerships with local charitable organizations. Outside of all of this work, she finds immense joy in her roles as a wife of over 14 years, a mother to 2 young men in their early 20s, and she's a devoted pet parent. She cherishes precious moments with her loved ones, indulges in creative crafts, travels to visit family, finds fulfillment in exercise classes and outdoor adventures, enjoys many vacations, delights in culinary experiences, finds solace in church and Bible time, immerses herself in reading, and embraces every aspect of life with gratitude and enthusiasm. Guided by her faith, her mission is to live each day according to God's plan, thriving in every moment. And it is my absolute pleasure to introduce her. Julia, the floor is yours.
Wow, thank you so much for that wonderful introduction, Casey. I'm really happy to be here, and I find that this topic is very dear to my heart because it's definitely part of my diagnosis. So I'm looking forward to hearing all the great things that we get to experience in here and learn today. So thank you so much. Without further ado, I would like to introduce our guest speaker today, Dr. Adrienne Wax. She is a senior physician in breast medical oncology at the Dana-Farber Susan F. Smith Center for Women's Cancers, where she is the associate director of clinical research for breast oncology and an assistant professor at medicine at Harvard Medical School. She conducts clinical research to develop new treatment approaches for breast cancer patients, with a particular focus in HER2-positive breast cancer. She conducts translational research to better understand mechanisms of response and resistance to breast cancer treatment. Thank you for being here, Dr. Wax.
Thank you all so much for having me. Julia, that's an incredible biography. My biography pales in comparison to everything that you've done over the last decade. And I already have seen some wonderful questions in the chat, which are as if I planted them there, and hopefully we'll get to everything that you guys are wondering about today. So let me share my screen. There we go. All right, and I'll keep an eye on the time as well. All right, so as you heard, my name is Ada Wax. I'm a breast medical oncologist at Dana-Farber. I love doing all sorts of breast cancer research and breast cancer clinical trials, but I do particularly focus on HER2-positive breast cancer and think it's a really exciting area in breast cancer treatment and research. So excited to share some of the developments with you today, some of the ongoing research that I think is exciting. So, by way of two really quick introductory slides, as many on this presentation are likely already aware, metastatic breast cancer refers to cancer that's become detectable outside the local area of the breast and the underarm and associated lymph nodes. A metastatic diagnosis develops in about 20% of patients who are treated for an early stage breast cancer. And it's actually a pretty small minority of patients who have metastatic breast cancer at the time of their initial diagnosis, although actually that figure is significantly higher among patients who are HER2 positive. In general, the treatment is not curative. It's about control, long-term control and quality of life with metastatic breast cancer. Although if there's one subset of metastatic breast cancer where we're moving the needle on that, it really is HER2-positive metastatic breast cancer across all breast cancer subtypes. But again, especially I think in HER2-positive breast cancer, new medications have really dramatically improved outcomes for patients. We know that when a patient has metastatic breast cancer, there are times when we use treatments like surgery and radiation, but medication treatments, what we call systemic therapy, are really the mainstay of the treatment tools that we use. There's a long list of treatment options, and in general, we pick a treatment that we think is the best fit for a patient. We continue it as long as it's working and as long as there are no, unacceptable side effects. We check labs periodically, we do scans periodically, and obviously we meet with our patients to understand what their experiences of the medicine and its side effects in order to decide how long we should keep a given medicine going. So delving into HER2-positive metastatic breast cancer specifically, we have a lot of targeted therapies that target the HER2 protein, which is the key growth protein, or at least one of the key growth proteins that's sending sort of bad growth signals to cancer cells in HER2-positive metastatic breast cancer. In general, we have HER2-targeted antibodies, which are margetuximab, trastuzumab, and pertuzumab. We have HER2-targeted ADCs, or antibody drug conjugates, like trastuzumab deruxtecan, which is TDXD, or Enhertu, and trastuzumab emtansine, which is TDM1 or Kadcyla. And then we have HER2-targeted what are called tyrosine kinase inhibitors, TKIs, which target the HER2 in a different way. You can see the antibodies sort of attached to the HER2 and inhibit it from the outside of the cancer cell, whereas the tyrosine kinase inhibitors like tucatinib, lapatinib, and neratinib, they inhibit the HER2 from the inside of the cancer cell. But at the end of the day, all of these different medicines are focused on stopping the growth signaling from that HER2 growth protein. In terms of just a little bit of history of HER2-positive breast cancer, so the HER2 gene was discovered back in the 1980s, which wasn't so very long ago now. The first anti-HER2 treatment was FDA approved for patients with HER2-positive metastatic breast cancer in 1998. That was Herceptin, or trastuzumab. So it's been between 25 and approaching 30 years since we've known about HER2 targeted therapies for HER2 positive breast cancer. And then in the 15 years or so after that, we saw a few other FDA approvals for new anti-HER2 medicines, lapatinib, pertuzumab, TDM1, between 1998 and 2013. And in the last 10 years or so, and really accelerating, I would say in the last 5 years, we've seen a lot more medicines FDA approved for HER2 positive breast cancer, including the antibody drug conjugate trastuzumab deruxtecan or Enhertu, other HER2 tyrosine kinase inhibitors like neratinib or tucatinib, a newer anti-HER2 antibody called margetuximab. So, we've seen the pace of drug development here, I think, really accelerating as the last few decades have gone on, which is exciting to see, and hopefully we'll see more of that. So in general, when we're treating a HER2 positive metastatic breast cancer, this has historically been the treatment, the sequence that we've followed. So in what's called the first line, meaning the first treatment that we try for patients, we use the regimen THP, and I'll get into more details on these in the next couple of slides, which is a chemotherapy with trastuzumab and pertuzumab. We call trastuzumab and pertuzumab HP. And then we had been using in the second line trastuzumab deruxtecan or Enhertu. Frequently then in the third line, we would use the chemotherapy capecitabine with tucatinib and trastuzumab. And then in the fourth line, use medicine TDM1 or Kadcyla, and have a bunch of other sort of options when we were using the fifth treatment, the sixth treatment, things like that. But there have really been two important updates within the last year, which are summarized in this box here. And so one is that, and we'll go through these data, we may end up now moving trastuzumab deruxtecan or TDXD to the first line for some patients, sort of displacing the THP. And for some patients, we may add palbociclib to the maintenance therapy that's a component of that THP regimen. So we'll go through some of those data, which have just been coming out over the last year or so. And of course, we always encourage, and I personally always encourage all my patients to consider clinical trials at each step of their treatment course, at least to ask your doctor and your treating team, is there a trial that might be a good fit for me now? Because all of these regimens that we're going to talk about today, all of these agents are here because of patients who have participated in clinical trials over the years. We couldn't do that without, incredibly brave patients stepping forward to help us learn about these new drugs and help us compare, the new drugs to the old drugs and develop things that are better today than they were previously. So the original phase 3 trial that showed the benefit of pertuzumab, which the brand name of that is Perjeta, for patients who have HER2 positive metastatic breast cancer was called Cleopatra. And this was a trial for patients with HER2 positive metastatic breast cancer who'd had no previous treatment for their metastatic breast cancer. It enrolled about 800 patients between 2008 and 2010. The results were first published in 2012, so it's been about 13 years since we've been using this regimen. And basically, this clinical trial compared trastuzumab with the chemotherapy docetaxel and pertuzumab with just trastuzumab and docetaxel by themselves with a placebo. And when we compared these two regimens, we found that the triplet regimen, the arm with the pertuzumab in it, was superior in terms of how long patients got good disease control for their HER2 positive metastatic breast cancer and how long they were able to stay on the regimen without progression of their cancer. And so in HER2 positive metastatic breast cancer, this was really, the first demonstration that using two anti-HER2 medicines, the trastuzumab and the pertuzumab together, was better than using one anti-HER2 medicine with this chemo backbone of the docetaxel. And so again, Cleopatra in this phase 3 trial 13 years ago now that it came out showed us that more patients experienced a tumor response. There was a longer length of tumor control and patients lived longer. There was longer overall survival if you incorporated the pertuzumab into the regimen. And again, I think a key sort of just bottom line message from this trial was that 2 anti-HER2 medicines were better than one, at least in this case. That hasn't been true in every trial, but in this trial, clearly pairing the two led to better outcomes for our patients. In terms of the side effects of the THP regimen, so the T there is a taxane type of chemotherapy, either docetaxel or paclitaxel. We know that chemotherapy drives a lot of the side effects of this regimen, like low blood counts, fatigue, hair loss, nail changes, taste changes, potential for neuropathy, which can be a really important side effect. The trastuzumab and the pertuzumab are the anti-HER2 antibodies. So I always call these sort of the workhorses of the regimen. And luckily, even though they are the workhorses of the regimen, they don't add too much in terms of side effects. Usually a lot of the side effects are driven by the chemo. But the trastuzumab and the pertuzumab, as with any anti-HER2 treatment, they can cause decreased heart function and occasionally allergic reactions. But decreased heart function is really the main side effect that we have to watch for carefully on our anti-HER2 antibody medicines with things like echocardiograms, which is an ultrasound of the heart. So from, again, 2012, which was the time that the Cleopatra trial was published, up until this year, when we've been treating our HER2-positive metastatic breast cancer patients in the first line, we've used what we call the Cleopatra regimen based on the Cleopatra trial, which is THP. And as many on this call probably know how this works is that you use a taxane chemotherapy, either Taxol or Taxotere. Usually you give that for 18 to 24 weeks in conjunction with the anti-HER2 antibodies. And then you stop the chemotherapy, you stop the T or the taxane, and you just continue on the maintenance treatment with trastuzumab and pertuzumab. For patients who also have an estrogen-driven, a hormone-driven component of their breast cancer cells, then when we get to the maintenance portion of this regimen, we add an anti-estrogen medication, which is called a hormonal therapy, like letrozole, anastrozole, or exemestane. And so this has been for, say 13 years, our standard approach. But it's been very exciting since we hadn't budged over more than a decade in that standard, that in the last year, we've now seen evolution of our first-line treatment options, or hopefully will see evolution of our first-line treatment options to expand our menu and have things that can work even better for our patients. So one line of new data that we'll look at is using trastuzumab deruxtecan, or TDXD, or Enhertu for some patients in the first line. And second is the addition of palbociclib, which is a CDK4/6 inhibitor called Ibrance, to the maintenance therapy portion for those patients who are estrogen-driven and HER2 positive for their breast cancer. So to talk a little bit more about TDXD, let's briefly discuss what's an antibody drug conjugate or an ADC in general. So ADC medications are these sort of modular type of cancer medications, very broadly used over the past 5 years or so, that incorporate 3 different components. So the first component is an antibody. And in this case, a lot of the treatments that we'll talk about are an antibody specifically against HER2, because we're talking about HER2-positive breast cancer, although the antibody could target all sorts of different proteins. But in HER2-positive breast cancer, it's often an antibody targeting HER2 on the cancer cell surface. And then there's a linker, and the linker attaches that antibody to the chemo drug. And, I think a lot of the time you might think, I would certainly think, the linker is really not that exciting, really not that interesting, not doing really much of the work of these kind of therapies. But it actually turns out that the way that the linker is designed and its properties and how tightly it holds on to the chemo, how easily it lets go of it, things like that, actually can make a very big difference for how these drugs work. So the linker is important. And then the third component of an antibody drug conjugate is a chemo drug, which we call a toxin, or a chemo, or a payload. And basically, that's the molecule that's attached by this linker to the antibody so that the antibody can deliver the toxin, the chemo drug, to the HER2 positive breast cancer cell. And you can tell, again, this is very modular design. You can have antibodies that target different proteins. You can design your linkers differently so they have different properties. You can add on different chemo drugs. So there's a lot of potential with ADCs to change the targets, change the ingredients, and make them work better or differently depending on what patients need. So this is a very exciting technology. Actually, HER2 positive breast cancer was the first type of solid tumor where we were using antibody drug conjugates in the first place across all of solid tumor oncology. So for a number of years, over 10 years, we've had the antibody drug conjugate trastuzumab emtansine, or TDM1. The brand name of that is Kadcyla, in use for patients with metastatic HER2 positive breast cancer. And then more recently, we've started using, over the past couple of years, trastuzumab deruxtecan as a newer antibody drug conjugate. So just to go over some of the data focused on Enhertu, or T-DXd, trastuzumab deruxtecan. The initial key trial of this agent for HER2 positive metastatic breast cancer was called DESTINY-Breast03. This was a randomized phase 3 trial that showed the benefit of the agent after other treatments had stopped working for HER2 positive metastatic breast cancer. So about 500 patients enrolled in this trial and were randomized between trastuzumab deruxtecan, or Enhertu, which was the new drug, versus the old standard of trastuzumab emtansine, or TDM1, aka Kadcyla. And this result was published first in 2022, so it's only been about 3 years, and showed us very clearly that trastuzumab deruxtecan, or Enhertu, performed better here and beat out the TDM1. So the newer antibody drug conjugate was significantly better than the older one in terms of how much it helped our patients. The newer trial that was just presented in June of this year at the ASCO conference was called DESTINY-Breast09. And so this was a phase 3 trial that showed benefit of the same drug, Enhertu, in this case combined with pertuzumab, in the first line, so before patients got any other treatments for HER2 positive metastatic breast cancer. In these two arms of the trial, there were 770 patients who enrolled and were randomized between trastuzumab deruxtecan with pertuzumab, or the old standard I showed you, which was the THP regimen. And in this case, the trastuzumab deruxtecan with pertuzumab was the winner. The patients were able to get disease control for longer if they got trastuzumab deruxtecan with pertuzumab compared to the old standard. So obviously a really exciting result for some of our patients. I will say there's a third arm of this trial that we don't know the results of yet. It hasn't reported, which is just trastuzumab deruxtecan by itself compared to the THP, because you could ask me, well, I'm really excited about the trastuzumab deruxtecan drug, but I don't know if I really need the pertuzumab alongside it. And my answer would be, that's a great question, and I don't know either. So we will see a third arm of this trial readout at some point in the year or next few years to come to see about how the trastuzumab deruxtecan by itself performs here. There may be many on this call who have received T-DXd or Enhertu, but just to go over the side effects, definitely this is a drug that can have a lot of side effects for our patients. For a subset of patients, it causes a fair amount of nausea. It can cause hair loss, although it doesn't always. It causes hair loss in about 40% of patients. As with almost any chemotherapy, it can cause fatigue or be a little bit immunosuppressive, can cause decreased heart function, as we see with pretty much all anti-HER2 medicines. And then the really key side effect that we are super vigilant about is that it carries about a 10 to 15% risk of causing lung inflammation, which can be serious if we don't recognize it and jump on it quickly. And so we're very attuned to how your breathing is. Are you coughing? Do you have shortness of breath for any patient who is on this drug? And we look at CT scans of the lungs very regularly for anybody who's on this drug. The other trial that has been really exciting, that one of the initial chat questions I know was already about for patients with HER2-positive metastatic breast cancer that came out, was presented in December 2024, is called PATINA. And so this was a randomized phase 3 trial that established the benefit of adding palbociclib, which is a drug with the brand name of Ibrance, a CDK4/6 inhibitor, to endocrine therapy or anti-estrogen medications combined with trastuzumab and pertuzumab during the maintenance phase of the THP regimen. And so this was a trial for about 500 patients with HER2-positive metastatic breast cancer that was also hormone receptor positive, so also estrogen driven. They all received the THP, they completed the taxane chemotherapy, and then they moved on to maintenance. And the maintenance options here were trastuzumab with or without pertuzumab. Most patients got pertuzumab with endocrine therapy, anti-estrogen medicines. And in one arm, the patients got palbociclib, or the CDK4/6 inhibitor, and in the other arm, it was just the anti-HER2 medicines, the anti-estrogen medicine, and no palbociclib. And when patients were followed to see how long the duration of their cancer control was, the arm with the palbociclib or the Ibrance did better. They had longer control of their cancer by adding this additional medicine into their maintenance regimen. And so, I think this was a very exciting result in general, because obviously we saw that adding a new agent could help patients stay longer and get better control with this therapy. But also in a very broad way, I think it proved the point that we can positively impact outcomes in HER2-positive metastatic breast cancer, even when we're hitting targets other than just HER2, because this palbociclib drug has nothing to do with HER2. It's a drug that we have typically used in HER2-negative breast cancer up to this point. And so I think that was a really important demonstration of the fact that there are definitely other growth factors, growth pathways that matter here. And by understanding them and inhibiting them, we can help patients more. So we want to focus on the HER2 protein. Of course, it's extremely important, but we also want to consider other growth pathways that matter in these cancer cells and be targeting those pathways too. I mentioned tucatinib and this class of drugs called HER2 TKIs, or tyrosine kinase inhibitors. So because this is another really widely used class of drugs, really important drug that, again, we know helps patients live longer when they receive it if they have HER2-positive metastatic breast cancer. I just wanted to focus for a minute on what is tucatinib. So this is an oral medication, it's a pill. This is also an anti-HER2 medicine, but as we said at the beginning, it targets HER2 protein from the inside of the cell. So it's inhibiting the same growth protein that we know is important, but in a different way than medicines like trastuzumab and pertuzumab. The sort of seminal trial that established the activity of tucatinib for patients with HER2-positive metastatic breast cancer was this trial called HER2CLIMB. This was a 600-patient trial. Results were first published in 2020. This was a trial where patients were randomized to receive either trastuzumab with capecitabine and tucatinib. So tucatinib was the novel agent here, or just trastuzumab and capecitabine alone without the third agent. And the tucatinib arm did better here. And so we learned definitively with this data set that this is an active agent and it can improve outcomes also for our patients with HER2-positive breast cancer. Some of the other sort of key findings here, again, there was a longer length of tumor control with the tucatinib, longer survival of patients with the tucatinib. There was a really important focus in this trial on patients who had brain metastases, which we know is a problem that particularly affects HER2-positive breast cancer patients. And the patients who received the tucatinib in this trial had a longer time to development of new brain metastases. And if they already had brain metastases, they got a longer length of tumor control with the tucatinib. So tucatinib worked well in general, and then really importantly, seemed to have important activity in the brain as well. And so, I think two important lessons from this trial. One was just how well this agent works inside the brain. And two was, again, reiterating that same lesson that two anti-HER2 medicines were better than one. All these patients were getting trastuzumab, but when you added the tucatinib, patients did even better. So again, a case where 2 anti-HER2 medicines were better than one, same lesson that we learned in Cleopatra. Just to stand on a brief soapbox that I'm sure many of you or all of you agree with here, to talk about the importance of incorporating patients with brain metastases into clinical trials, which that trial I just showed, the HER2CLIMB trial, was really the first trial to do this in a thoughtful way. For many, many years, patients with what are called active brain metastases, meaning they haven't seen a treatment like radiation therapy, or they've received radiation therapy to a brain metastasis and it is still growing. Historically, patients with that type of brain metastases were not allowed into any clinical trials, certainly not any, big clinical trials, which makes it really hard to know, obviously, how each drug was working in the brain. But in recent years, the great news is that that's changing. It's changing especially quickly in HER2-positive breast cancer. And so, I think patient voices and patient engagement have moved forward every single field in breast cancer research, but I think here in particular is an area where patient advocacy and the patient voice was really, really important and really impactful to remind all of us how important it is to include patients with brain metastases in clinical trials. So thank you for your work on that, and definitely keep it up. We still have a ways to go there. On that note, we have made progress in incorporating brain metastasis patients into clinical trials. And so just to highlight the trial called Destiny Breast 12, this was a trial that was specifically geared towards understanding how Enhertu works for patients with brain metastases. So this was a really straightforward clinical trial. Patients had metastatic HER2-positive breast cancer. They had received some previous treatment, and everybody got the drug, T-DXd or Enhertu. They just enrolled a cohort of patients who had brain metastases and then a cohort of patients who didn't. Everybody got the same drug, and they were all just followed to see how did the cancer treatment work. And the bottom line from this trial is that the Enhertu medicine looked like it worked exactly as well inside the brain as it did outside the brain, which is, hugely important data. Really good news, really reassuring, and helps us feel comfortable when we use this drug in a patient who's experienced a brain metastasis. And again, it's just been historically very rare to get data sets like this, so it's wonderful that this is becoming more mainstream and we're getting this data in a really, high quality way, large clinical trial kind of setting. So to sum up this first section, again, we have many treatment options for people who are living with HER2-positive metastatic breast cancer. Just within the last year, we've seen 2 really exciting developments for our selection of the very first treatment, that first-line therapy that we give to these patients. There's no one size fits all here, definitely. So how we sequence from one treatment to the next depends on how good is our disease control and what side effects are you experiencing. Of course, we try very hard to partner with patients as much as we can all along the trajectory of care in order to optimize symptom management. And the good news is that in 2025, we do see longer survival, better quality of life in many patients, which is great news. And at the same time, still lots of progress to make and improvements to make here. So on that note, and in the final few minutes, let's talk about the research landscape in 2025 for HER2-positive metastatic breast cancer. I could talk for 3 hours about this, so we will try to just highlight some, I think, some themes and agents to look out for that I'm excited about. So we talked about antibody drug conjugates. Obviously, again, in HER2-positive metastatic breast cancer, HER2 itself is the obvious target for an antibody drug conjugate. So just to briefly say that, there are many, many, many HER2-targeted antibody drug conjugates that are currently in development, changing the structure of the antibody a little, changing the linker a little, changing the chemo component to try to really figure out, which one of these is the best technology that can get the best outcomes for patients. So a long, long list of new HER2-targeted ADCs. Here's just one example of a drug that I think looks interesting called disitamab vedotin. There's a clinical trial of this drug combined with tucatinib for metastatic HER2-positive breast cancer. So here's one example of, I think, a nice new HER2 targeted ADC that's in development. We don't want to be short-sighted. We don't only want to target or look at, the impact of targeting HER2 and HER2-positive metastatic breast cancer. So, we're looking at other antibody drug conjugates as well and other protein targets on the cell surface. Another drug that we know works really well in HER2-negative metastatic breast cancer is sacituzumab govitecan, or Trodelvy. This targets a TROP2 protein on the cancer cell surface. So in a trial that we're leading here called SATINE, we're looking at this drug combined with trastuzumab for HER2-positive metastatic breast cancer. What about targeting other cancer growth pathways in HER2-positive metastatic breast cancer? I already showed you that this idea was really well supported by the PATINA trial, showing us that, again, we can move successfully beyond HER2 for HER2-positive breast cancer patients if we use a medicine like Ibrance. So what about other cancer growth pathways in HER2-positive metastatic breast cancer? Well, one of the key targets that we are interested in evaluating for HER2-positive patients is PIK3CA mutations. About 30% of patients with HER2-positive metastatic breast cancer have PIK3CA mutations. Looking for this mutation is a reason to get tumor genetic testing if you have HER2-positive breast cancer. And if we find this mutation, as we will in about 30% of patients, there are a number of different trials going on. Here's an example of one of them, to look at medicines that target this PIK3CA growth pathway and understand if we can target that and improve outcomes in HER2-positive breast cancer. This is a trial specifically using a drug that inhibits this pathway called inavolisib, which is FDA approved in HER2-negative metastatic breast cancer. But again, it may very well work in HER2-positive metastatic breast cancer. We just have to sort that out. And then just to the final two slides, I wanted to highlight two ways in which I would say we're sort of thinking outside the box for our patients with HER2-positive metastatic breast cancer in ongoing research. So the first is based on the premise that we really, as I hope I've shown you and as I hope you've experienced, we have excellent medicines that target HER2. We have many of them. We do see some patients with a very long length of tumor control with HER2-directed medicines for HER2-positive metastatic breast cancer. And so, one question where we're very interested is, how can we use the current drugs we have, which are very effective, in a better, smarter way to get long-term tumor control in more of our patients? And so another trial that's going on nationally is called the SAPPHO trial. This is a trial looking at a really intensive upfront regimen for patients who are newly diagnosed with HER2-positive metastatic breast cancer. So this is not for a patient who's gotten treatment before. This is for somebody who's just newly diagnosed. And it's basically a trial that's looking at stacking in pretty quick succession a lot of the different agents that I just showed you, and trying to move a patient pretty rapidly amongst them in an effort to eradicate as many cells as we possibly can and as many resistance pathways as we possibly can, hopefully maybe translating into long-term better outcomes long-term, because we've stacked so many of these treatments sort of early on. So this is a trial that's enrolling right now nationally. And then we also know, and this is being looked at in this trial called STOP HER2, that some patients can be on there with metastatic breast cancer, can be on anti-HER2 therapies for a very long time with good stability, 3 years, 5 years, 7 years, 10 years. Some patients get that long duration of control with medicines just like trastuzumab and pertuzumab. And what we end up asking ourselves sometimes in those long-term stability patients is, can we stop the drugs and still maintain that stability? We've had very little data to help us understand the answer to that question up to this point. And so the STOP Stop HER2 trial just enrolled a population of patients who had this long-term stability. Some of them chose to stop their anti-HER2 medicines. Some of them chose to continue, and they're all being followed for 10 years to see what happens when we stop or don't stop these medicines. This trial has completed its accrual, and so we're awaiting the results. And I think this will be really important and exciting when it comes out within the next potentially year or so. So with that, let me stop sharing and see what questions you have. Thank you for your attention. Hopefully you've learned something new, and I look forward to answering questions too.
Well, thank you so much, Dr. Wax. There are a lot of questions here, so you got us prepped and ready to go. The first one was, with HER2 positive stage 4, is it typical to start with hormone therapy first?
That's a great question. And again, I think there's a lot of controversy and unknowns about like when and how should we target the estrogen growth pathways, and when and how should we target HER2, because it's really clear that they are both important. So there's, again, is no one size fits all answer, but it wouldn't be standard, no, to target if we know that a breast cancer is HER2 positive, it would not be standard to only focus on the estrogen driven part of the cancer and to treat with only anti-estrogen medicines first. So usually we would start by targeting the HER2 protein and those growth pathways, and then potentially add on the anti-estrogen medicines to the anti-HER2 medicines later on. So I could envision scenarios where you wouldn't do that, but usually you think of the HER2 as sort of the predominant growth pathway here, and that would be the one that you target first.
Thank you. This is one I haven't heard of before, but how do you look at oligometastatic disease?
Right. Yeah, that's a hard question. That's a great question. And what oligometastatic disease means is that, yes, there's evidence that cancer spread somewhere else in the body, the lung, the liver, the bone, whatever, but it's only to a few spots. How many is a few? There's no standardized definition of that. Is it 1? Is it 3? Is it 5? Not sure. It's probably not 20, but it's spread to a few spots. And what we ask ourselves, especially for a patient with HER2 positive metastatic breast cancer who has just a few spots that we think are outside the breast that have cancer in them, what we ask ourselves is, does that mean that because we see so few of those spots, that this is a patient where maybe we have the potential to cure the patient and to eradicate all the cancer in the body because we see that there's spread, but it's not a ton of spread? And it makes a lot of sense that maybe that's a patient where we can have a higher likelihood of really long-term tumor control. But the truth is we don't know that at all. And so generally I treat oligometastatic HER2 positive breast cancer the same way that I treat HER2 positive metastatic breast cancer that has more widespread, evidence of cancer to other areas of the body. I generally don't take a different approach, but it is definitely an area of controversy.
Another one for you. I have ER positive, HER2 negative. Now, can I get HER2 positive later?
Yeah, it's a great question. Sort of generally, like, can the subtype of my breast cancer switch? Could I switch from HER2 negative to HER2 positive? Can I switch from HER2 positive to HER2 negative? Any of the different directions? And the answer is yes. As breast cancers evolve and change, it is possible. And we generally think we see in about 5 to 10% of cases that the type of breast cancer, whether it's estrogen positive or negative, whether it's HER2 positive or negative, can change over time. Again, I'd say in about 5 to 10% of cases. So it's unlikely, but it's not impossible. And always, if you and your doctor feel like something's just not making sense, like there's one spot of cancer that is just not behaving like the other ones, and I should have gotten longer out of a medicine than I did, things like that. It's always a reasonable idea to rebiopsy, especially again if there's like one area where its behavior just isn't jiving with what the rest of the cancer is doing and just isn't making sense. But it's not a super likely thing to happen, but it's not impossible.
Wow. Are there any vaccines in development for HER2 positive MBC?
Yeah, that's a great question. Oh, for MBC in particular. So there are definitely vaccines in development, although this isn't what you asked, for HER2 positive early breast cancer. There's a randomized phase 3 trial called Flamingo-01 that's looking at a HER2 vaccine. There are some other smaller phase 2 trials that I'm aware of that are looking at HER2 vaccines. And it's definitely an area of interest and I would say of promise. Vaccines are of interest and promise in any sort of breast cancer, but especially almost in HER2 positive breast cancer, where it seems so obvious that that HER2 protein is the one that you could create a vaccine against, that might be cancer specific. In terms of vaccine development, specifically in metastatic HER2 positive breast cancer, I can't think off the top of my head of a product that's moving really rapidly in that space. So there are probably some that I'm missing, but I know that in HER2 positive early breast cancer, there's a couple of really interesting vaccine trials that will be good to see the results of in the next couple of years.
Wonderful. So many questions. It's hard to pick. I gotta go. And let's see. If someone develops severe pneumonitis from 2 rounds of Enhertu, would Kadcyla have the same risk? Would it be a bad idea to try Kadcyla in that patient?
You're talking about lung inflammation, pneumonitis. Yeah.
I would. Oh, pneumonitis. Yeah.
Yeah, it's a great question. So in HER2, the drug absolutely can cause pneumonitis, which is inflammation of the lungs. Again, that's in about 10 to 15% of patients. In terms of how does that carry over to other drugs that we use in treating HER2 positive metastatic breast cancer? Pretty much any drug that we use across maybe all of oncology, but especially HER2 targeted drugs, they do have some risk of lung inflammation, also known as pneumonitis. TDM1 does too. Even trastuzumab and pertuzumab do. And so it's never a 0% likelihood of getting pneumonitis with really any of our anti-HER2 drugs, tucatinib too. But with those other drugs, it is much lower likelihood, like we're talking 1%, 3%, something like that. Whereas with the Enhertu drug, it's higher, 10%, 15%. I personally think that in most situations, it would be reasonable to try another drug like TDM1, trastuzumab, pertuzumab, any of them, even if a patient had pneumonitis on Enhertu, because it's just so much more likely on Enhertu. But you certainly might watch that patient more carefully, or something like that. But I don't think it's a reason that you wouldn't be able to use one of the other drugs. It's just so much more common with the Enhertu.
Thank you. Are there any plans to study outcomes for metastatic HER2 positive patients who undergo mastectomy versus those who do not?
Yeah, it's a great question. So, there have been multiple trials in metastatic breast cancer looking at whether we should do mastectomy for patients who have metastatic breast cancer. I'm talking across all subtypes, not just HER2 positive, across all subtypes. And in general, there have been HER2 positive patients on those trials. And in general, what those trials have shown is that getting a mastectomy didn't help patients, 3, 5, 10 years down the road. So usually it's not a strategy that we employ if we know a patient has metastatic breast cancer to do a mastectomy. That being said, I think the person who asked the question is astute that maybe the answer for all subtypes of breast cancer, maybe we shouldn't carry that over specifically to HER2 positive breast cancer. And the reason why not is that our medicines for HER2 positive metastatic breast cancer on average are better than they are for other subtypes of breast cancer because we know exactly which protein is the problem. We have so many great medicines to target it. So maybe the answer that we've gotten in general, which is no, we shouldn't do mastectomy. Maybe, maybe that's the wrong answer, and we should be looking more specifically in HER2 positive metastatic breast cancer. We don't have a HER2 positive specific answer to that question. There is a trial that will open. It's specifically for patients with oligometastatic disease, to the previous question, that will look at doing local therapies. So radiation treatments to, say, the liver or the bones, things like that, for patients who have only a few metastatic breast cancer sites. And in that trial, I believe that they will also have patients do a mastectomy if they have HER2 positive metastatic breast cancer. So there will be a trial. It will open through the what's called the TBCRC, the Translational Breast Cancer Consortium. Susan G. Komen is a big supporter of the TBCRC, so you all are helping to make this trial happen. And that trial will open. I'm forgetting what it's called. Oh, it might be called Archer, ARCHER, where the HER is like a play on HER2, So look out for that trial. It will open soon, and it will take a number of years to see the results. But that trial, which is led by Lior Bronstein, who's a radiation oncologist at Memorial Sloan Kettering, will help us start to answer in a HER2 specific population, what is the value of these local treatments, mastectomy, radiation, things like that.
Thank you. I'm trying to sneak in another question. How many lines of treatment are there for HER2 positive? Why do some people achieve no evidence of disease and others don't?
So first, I'll do the first question. Second, why do some people achieve no evidence of disease and others don't? And the answer is we mostly don't know. And so, that's a terrible answer to your question. And we need to keep working on this, and you can help us. But, we mostly don't know, or we're not great at sitting in front of somebody when we first meet him or her, and trying to map out like what are things going to look like for your cancer over the next couple of years. We mostly don't have an answer to how well is my treatment going to work, how long is it going to work for. And so, we can sort of make a guess at some features that are on average associated with getting better control or less good control. But for any given individual, we can be very wrong. So we don't know the answer to that question. In terms of how long, how many lines of treatment are there? I mean, the answer is, I don't know, 40. There's a lot of different lines of treatment available. And if you incorporate clinical trials into your overall course of therapy, which is always my preference, then that list gets even longer as we bring in sort of newer drugs that are just being developed or combined in new ways or things like that. So I would say, especially in HER2 positive breast cancer, we have a really, really long list of options. But the disappointing flip side of that is that there are still some patients for whom we try option after option and they don't work as well as we think that they should. So we have to figure out why that is. We have some of the answers, but clearly not enough of the answers.
Wow, thank you. I think they're letting me ask one more. How are clinical trials for HER2 positive being impacted by government cuts in research funding?
Yeah, that's such a good question.
How about that one?
Right. Oh, it's an easy, quick one to close us out. Yeah, it's such a good question. I mean, the truth is that what I worry about, a lot of the like trials that are going on now that have currently, that have already sort of started, and are pretty far along in development, at least in my experience over the last year or so, they really haven't been affected. A lot of trials are funded by drug companies. Drug companies really do very important work helping us with drug development, and a lot of those have not been affected. So that's the good news. What I think is more worrisome, and where organizations like Komen have always been important and are especially important now, is more the work that's going on really early on, where there are scientists in labs and they're trying to figure out which pathway matters, and they're designing that linker technology that I barely understand, and they're figuring out should it point this way or that way, and they're doing chemistry and, that sort of thing. That's really sort of basic, and it's really the basic building blocks of cancer research where it's not so obvious. Is this going to help, or is this going to be meaningless? And I'll be, and I'm going to abandon this line of inquiry. That sort of early experimentation, which goes, is a lot at sort of academic campuses across the country and across the world. I think that's what is most affected by these cuts. This is my personal opinion. And I think that those impacts will take longer to feel. Because it's more, again, it's the building blocks. Like we just might, we attract fewer young scientists who want to work on those questions, and we don't have as much funding for the young scientists who want to work on those questions. And that I do think can translate into, unfortunate impacts later down the line that we're not necessarily seeing now, but, could see in years to come. So that's really my fear, and I don't want to end on a sour note, but that's where Susan G. Komen comes in, and trying to help fill some of those gaps. Like I said, has always been important, but is especially important now.
And a plug for fundraising.
There you go. Yes.
Well, thank you so much, Dr. Wax. We really appreciate all your time and your expertise. And I know there are more questions out there, so I'm sure Casey will address that and figure out a way to get those answered. So thank you again for joining us.
Thank you, everybody.
All right, Dr. Wax, thank you so much for tackling that really small last question, but I know it is something that, breast cancer patients, especially stage 4 patients, I mean, it's been stressful for them seeing what's been going on. So I appreciate you even attempting to answer it at all. So yes, we had a ton of questions, guys. Obviously, we did not get to all of them. My apologies. What I'm going to do is when I send out the recording for the event, you'll see me attach and send a lot of links to different HER2 positive resources that we have or other organizations have to try to help get those questions answered. And also, I just always have to plug, please don't be shy about talking to your care team and your providers about your very specific treatment-based questions or what to anticipate, how to manage side effects, because they really are going to be able to give you such specific answers and response that is tailored to you and where you're at and what your treatment is going on. And if they're not giving you answers that are adequate, don't be shy about getting a second opinion or finding somebody who will. I don't say that to put anybody off. We always do our best to get everybody's questions answered, but I also know that sometimes patients are a little shy, and I just want to encourage you not to be. And when you're in that room with your doctor, that is your time. So please, pester them until they give you your answers. Anyway, it has been a lovely, lovely Wednesday afternoon with you all. Thank you so much, Dr. Wax and Julia, Dr. Julia. She's an honorary doctor now, I guess. Julia, for your expertise and experience on this topic. Again, guys, today's session was recorded and it's going to be posted to our YouTube and our landing page. It'll be emailed directly to you. You can also log into our YouTube channel and rewatch previous sessions. Again, I'll send some HER2 positive specific links in that email, but please share and spread the word. This could help educate friends or family or even other healthcare professionals when you're trying to ask your questions or navigate your diagnosis. So if you want to stay up to date with all of our topics and our presentations, go to komen.org/MBC series and sign up for our newsletter, because we always send this information out ahead of time as best as we can. So one last acknowledgement for our sponsors. Thank you to AstraZeneca, Merck, and Gilead, our premier sponsors, and to Daiichi Sankyo and Novartis, our signature sponsors. Without them, we wouldn't be able to provide all this amazing content month in and month out for you guys. So very grateful to just mention them right now, and I'm double working right now, so forgive me for that. Last but certainly not least, I just dropped a link in the chat again. It's that survey that I mentioned at the beginning. Please take a second, fill it out, give us the good, the bad, and the ugly. Let us know who you want to hear from and what topics you want to hear more about, and that's how we design our whole programming calendar every single year. Finally, our next event will not be until November. We take October off, but that's going to focus on communicating with family and friends about MBC and your diagnosis. So stay tuned for details coming out. Once we secure that date and speaker, we'll make sure that information finds its way out to all of you. So thank you so much for everything today. This was a great session, and I hope everyone has a lovely day.
Thank you.